Welcome, everyone, to this month's seminar on spirituality and health. And today we have a real treat because we've got two terrific people who are going to talk to us about integrating spirituality and meaning in medicine. Dr. Bruce Feldstein is kind of the lead presenter. He's an adjunct clinical professor at Stanford University School of Medicine. He's a board-certified chaplain and founder and director of JFC's Jewish Chaplaincy Services, serving Stanford Medicine. He's a graduate of the University of Michigan Medical School, and after specializing in emergency medicine for 19 years, an injury led him to a deeper sense of his life's work as a chaplain. Bruce was a visiting scholar at Stanford Center for Biomedical Ethics, then completed his chaplaincy training in 2000 in Stanford's Clinical Pastoral Education program. He leads Stanford's Reflection Rounds, teaches courses on spirituality and well-being, and heads the Stanford Lifestyle Medicine Pillar on Gratitude and Purpose. He received the John Templeton Spirituality and Medicine Curricular Award, the G. Wish Templeton Reflection Rounds Award, and was the first recipient of the Isaac Stein Award for Compassionate Care presented by the Stanford Healthcare Board of Directors. Now, Akiva Northern holds a doctorate from Loma Linda University, where she received the Dean's Award for Intellectual Achievement, Professional Performance, and Social Sensitivity, and the Will Alexander Award for Compassionate Care, and a Master of Divinity from Yale University. Akiva studied at Howard University School of Medicine until she had to become a full-time family caregiver. Now at Stanford University School of Medicine, Akiva works with Bruce Feldstein to facilitate reflection rounds for medical students on core clinical clerkships. Akiva's groundbreaking dissertation on reflection rounds, entitled The Joys and Challenges of Medicine, a phenomenological, phenomenological and theological exploration, explored medical students' reflections on their care of patients. As a chaplain in healthcare and medical education, Akiva provided spiritual care for hundreds of patients, families, medical students, and physicians. As an ecological chaplain, Akiva led people to the Kilimanjaro Mountains, along Niagara Falls, and the Pacific Ocean, where she discovered that listening, storytelling, and meaning-making in nature are sacred and healing. So with those introductions, I'm going to turn it over to Bruce Feldstein, who can take it away.
Thank you, Harold. Thank you so much. And how good to be together in such good company. How good to be together. So I want to thank you, Harold, for inviting me. Something sparked you to invite me out when I commented at a previous talk. And it's given us an opportunity to look over the past 25 years of the work that I've done after moving from emergency medicine to becoming a chaplain. I'm a physician, a chaplain, and an educator. And we've been integrating spirituality and meaning into medicine. It's one of the core things that is important to me in my work, in my service. So it's a chance to glean from that work a few highlights that I'd like to share with everybody here. I've done and been involved in research myself on a number of projects. I cannot say that I am a researcher. I'm a practitioner. And along my way, I came to meet Akiva Northern. Say hello, Akiva, to everybody.
Hello, everyone. Good morning. So good to be here. Dr. Koning, thank you for inviting us.
Yeah. So let me get my So, greetings from sunny California. So, there's four general times that we're going to spend together in conversation. First, to talk about some of the early courses and early work. And there's some key distinctions that we've developed that we want to be sure to share with you. Second is a main focus today on reflection rounds. Maybe that's new for you. If it is, well, you've just heard about it. It was developed by Christina Puhalski at the George Washington Institute on Spirituality and Health. And we introduced it at Stanford in 2014. You'll hear about that. And then this became the topic of Akiva's dissertation, which you'll hear. And then at the end, as we have some time, we just want to touch on a few ideas that we're continuing to explore, ideas that actually would invite your input too in some of the question and answers and on all of this. So here we go. At Stanford, I went from emergency medicine. I was a founding faculty there. And during that time, I found myself surprisingly praying with a patient in the emergency department, not something that I'd ever done before. And it was very clear at the moment, and it was so truly the right thing. Her name was Mrs. Martinez. And at the end of the prayer, she had previously said the cancer is to hear the diagnosis of the cancer spreading to my brain, doctor, it's a death sentence. And I searched for how I could possibly respond to her. I couldn't fix her. I couldn't cure her. I couldn't be with her emotionally. And I saw she was wearing a cross. Now, I'm a Jewish physician, but I knew in that moment that I needed to offer a prayer to her. I had heard about this, but had never done that before. And I asked her, Mrs. Martinez, are you a prayerful person? She said, yes. And that began our prayer. I had never done this kind of thing before. And afterward, she went from the color being fully drained from out of her face, like white, and looking down. And at the end of the prayer, she looked at me right into my eyes. The color had now fully returned. She had tears streaming down her cheek, and she said to me, in a way I'll never forget, thank you, doctor. Thank you. And I just knew in that moment I had done the right thing. It was the right medical thing. It was about providing comfort when I could. But I'd never prayed with someone before. And then in the very next moment, I thought, what did I just do? I prayed with a patient. Isn't there a separation of church and state? Oh my God, what if I get arrested? What if I get reported to quality improvement? Oh, I am head of quality improvement. So I was, Harold, I was in quite the cognitive dissonance. And I went to our Center for Biomedical Ethics to Ern Lee Young from South Africa, a minister, but who is a PhD and head of the ethics. And we put it under the ethical microscope. And he showed me how what I did was how it was ethically absolutely grounded. And then that became the topic of a grand rounds. And it was the first time, Ernley said at Stanford, and this was in 1999, that we had presented something on spirituality and prayer and this aspect in medicine. So that was a beginning. When I could no longer practice emergency medicine, I went on to become a chaplain. And during that time, family medicine got a grant from HHS to introduce taking a spiritual history into the medical curriculum. And they recruited me to join the team, which I became one of the leaders of. And then we later went to get a GWISH, George Washington Institute on Spirituality and Health, a curricular award to develop some courses. And in that, we came to see, I'll just move on to that. It was a required class. This was our pioneering effort. It was during the required family medicine core clerkship. Our team included myself, a Catholic nun who was a former nun, Catholic woman who was an ethnogeriatric care educator. We had a Buddhist psychologist, and the head of the department was a humanist. And together we titled the course Spirituality and Meaning in Medicine. Intuitively, Sam LeBaron, should rest in peace, understood that all of our very scientific PhD-oriented students, we have about 20% of those at Stanford. For many of them at that time, they might not appreciate the word spirituality because it was always so associated with religion. But he said, let's call it meaning. Nobody can disagree with that. And we did. And a key thing that developed, our goal was for the students to be able to identify and respond to their patient's spirituality and their sources of meaning, as well as for the students themselves. So we were operating, it was a both and in this relational context for the provider, the student, the physician when we teach it, as well as for the patient. They needed to learn to understand and embody a definition, a understanding of spirituality and meaning, not only in healthcare, but for their own life. So that became one of our objectives. And part of this was learning to prepare what we called their attention and intention before going into any encounter with the patient in order to make a meaningful connection. The other key distinction we came up with was identifying and responding to the patient's, we called it chief concern, not the chief complaint, which is common in medicine, the chief complaint about the biophysiology and pathophysiology and that, but the chief concern, which was about meaning. In a key exercise, after the students would go over definitions of spirituality, we would ask them, well, let's look at it for ourselves. Remember a time in your life that you would call a spiritual or deeply meaningful experience. And then we had some questions, and the students then reported in the group. These would be on the family medicine rotations, about 8 students with myself and my colleague as facilitator. And we would listen to their stories and mark on the board some of the key language that they used. And then afterwards, we would stop and see, what do we discover further about the nature of spiritual experience? And then how does this apply to being a practitioner at the bedside? So here's what we came up with, some of the key things. Well, first of all, every single person had something that they reported, everyone. And we discovered that whatever we call this spiritual or deeply meaningful experience was true for all human beings, and that it was unique for each person, so therefore was not reproducible. And that responds to some of the conundrum for researchers who are interested in looking at reproducible results. But for that individual, it's defined by them. Also, the events were a happening. For example, one person was sitting at a hiking in the mountains, and suddenly his eyes were closed. He was just enjoying the sun, and he felt a warm breath on his face, and there was the face of a moose looking right at him. It was a moment of awe as well as trepidation. And people went on to describe all kinds of things, but they were always happenings. It was not on anybody's calendar. These were emergent phenomenon. And where did they take place? Anytime, anywhere, including in church, including in worship, but at the ball field, out at even at the patient's bedside. We looked at the relational component. There was always something relational with ourselves, with others, the transcendent. And you can see some other on the slide, some other descriptions about it. After doing this for about 10 or 15 years, this became a permanent, we went on to create a permanent feature of something in the medical school, which was reflection rounds. And that's what I want to focus on now. That's what we're going to focus. So reflection rounds. I also heard about this through the work of Christina Puhalski. She had developed it, and Stanford became one of the pilot programs in 2014, and we've been doing it ever since. Now, so what is reflection rounds? For those of us who are in medicine, let's just say it's a different kind of rounds. It takes place in a classroom. We sit around a table. So we're sitting in the round. And it's an educational process, and it brings meaning, purpose, and connectedness into the education. And it's for medical students, and it includes practicing physicians. And as we sit in the rounds, I did one yesterday actually on Zoom. Um, we have typically a physician with a chaplain, or a physician and a counseling professional. In my case, Harold, I wear both hats when I facilitate. And we gather as colleagues, and we're off the evaluation grid, I tell the students. So we create a clearing that we can be together. And I say, do you know I'm your colleague? It's a way of emphasizing the nature of colleagues. So, and I say, yeah, now we're not peers. So what are colleagues? And this is important, key for us. Colleagues, what makes us colleagues is we've all said yes to medicine. It's about our common commitment. We've all said yes to medicine, each in our own way. So it's always a unique commitment, but we've all said yes. And that's the shared nature of being a colleague. And that's really crucial. And then during reflection rounds, we focus on our inner life experience. We focus on our own thoughts, reactions, images, feelings in the encounter. And we reflect on it, not only on what happened, but also in the context of who we are and our commitment, our formation. We look at the emotions. The emotions are gateways to meaning and wisdom that our analytical mind can't go. And I really came to appreciate that during my ethics training with Ernley, and then especially during my chaplaincy training. The, uh, the importance of the emotions, the moods, again, as what we'll call it a gateway to wisdom and meaning. And this idea of gateway, Akiva explores and came up with some really stunning observations. So we've done this with over 900 students. Our class size is small at Stanford, it's 90. We do it on required clerkships when they're on pediatrics, emergency medicine, and ambulatory medicine. We've also done it on surgery and family medicine. It's 2 hours. It's facilitated. As I said, it's a conversation among colleagues. And there's some ground rules, but we just share as it's comfortable. And let's listen with generosity, I like to say, with curiosity, with appreciation, in a mood of discovery. We're not here to fix or advise. So already it's a different kind of interaction, and we maintain the confidentiality where we do encourage people to continue the conversation, but not in a way that would identify anyone. Our focus is on the art of medicine, the spirituality, the humanity of medicine. Um, Recognizing medicine is not sometimes an art and sometimes a science. It's always simultaneously both art and science. So this is our initiative to bring forth not as separate from the science, but as integral, constitutive, essential part of who we are as human beings, who we are as human beings who are practitioners, who we are as human beings who are practitioners, human beings caring for and with other human beings. So that's some of the background. What I'm come to appreciate is the ontological background, the nature from the nature of our being itself. And then students reflect on a clinical situation that's of interest to them, maybe something that left them feeling incomplete or questioning or troubled. Or maybe something that's remarkable or they're grateful for, or maybe something that's got elements of both, or maybe it's something that just comes up. And then they reflect and they come back to the group, and they take turns sharing and exploring with each other. We're going to hear more about that when Akiva makes her presentation. And then we end the reflection round session with, so, what's one thing you're taking away from today's conversation? And in fact, we're going to do that today. So that's going to be one of our questions for you when we get to the Q&A. We have a question for you. So what's one thing you're taking away? Maybe a new curiosity or a question, or maybe an appreciation about yourself or the nature of our work itself. Um, this is just to say there's a bunch of topics that we do explore, themes that come up routinely. Akiva, take it away.
Thank you so much, Bruce. Um, I'm going to talk a little bit about the research. Can everyone hear me? Can you hear me well? Okay, good. I'm going to talk a little bit about the research, the reflection rounds research. And the title of my talk is Joys and Challenges of Medicine, a Phenomenological and Theological Exploration. So I love, Dr. Koning, how you stumbled on that word, phenomenological, because it has taken me many years to pronounce it well. It's not just hard to pronounce, but a little bit hard to understand, but we'll get into that. Um, and I see one of my mentors is on this line, Carla Park, who helped me to develop and think about research. I'm glad she's here. So I'm going to first begin the talk with my why, and then study purpose, methods, and population. A little bit about what is phenomenology, since it's a little bit of a research method that maybe is not as common as some others. And then the research results, model, and some implications. In particular, we're going to take, my dissertation had a lot of implications for medicine, for chaplaincy education, for the practice of medicine, but we're only going to take two today relative to this amazing 2024 AMA resolution on spirituality in medical education and practice. And then we're going to have a theological reflection on one of the study findings. So I'm going to begin with my why. Um, I'm going to begin. I said yes to medicine and got accepted to medical school when I was 52, which was just a miracle and a wonderful dream come true. But I got accepted, knew I wanted to do something with faith in medicine. So I got accepted to Yale Divinity School and Howard School of Medicine the same time. So I went to Yale for a year, and then I decided I'm going to do my 2 years of medicine. Uh, and I went on to Howard. And in anatomy lab, I had an experience that really, well, anatomy lab changed my trajectory actually, but I had an experience that I want to talk about. Um, could you go back, Bruce?
Yeah.
I had an experience of awe. The awe that I felt was as the result. This is the old days when anatomy was a real body. You really had a body to dissect. And I held a uterus, a womb in my hand. And I remember just being amazed that this little round ball in my hands could stretch and house a human being, a human fetus. I just, for, I just it was awesome to me to think that this organ was made and it could stretch that way. And I just was, it brought me to tears. And I remember one of my medical students, or one of the techs said, stop that. Shut up and memorize. And it shocked me so much. And I thought, I can't. This is just too awesome. This is amazing. And so I think what actually happened is I did not pass anatomy, and I for the second time, and I had to actually I honored in everything else, and I had to actually start caregiving for family members. So I wasn't able to finish medicine, but I never forgot that awe. Go ahead, Bruce. And so when I started thinking about research and I read Husserl, I thought, yes, Husserl, the father of phenomenology, said he believed that phenomenology is a way of looking at the world that reveals the essential meaning and often hidden parts of the lived experience specific to distinct groups of people. And I knew this is the method for me. So phenomenology is, he believes, perceives the experience of human consciousness in a way that is scientific. It explores human experience and the phenomena and the meaning of that phenomena and lets the phenomena speak for themselves. So in my study, I have a priori phenomena, joy and challenge. Joy is a significant term in medicine as well as religion. Joy in medicine is an ancient aspiration. You find that term in the Hippocratic Oath. And even today, the Joy of Medicine Awards that the AMA gives out. Joy in religion is a timeless virtue. The day is holy to the Lord. Do not grieve, for the joy of the Lord is your strength. And there are many texts about joy in the Bible. Challenges are also in medicine: physician distress, burnout, and suicide. And challenges and suffering are definitely a religious theme. So these were my a priori themes. The study purpose was to explore the lived experiences of medical students during their patient encounters when they took their core clinical rotations. When they're meeting patients for the first time, it's a critical time for medical learners because up until now, most of their life, it's been objective learning. But all of a sudden, they face real human beings with real problems that medicine sometimes cannot solve. And it can be shocking. And reflection rounds is an opportunity for them to engage in meaning making about those experiences. And these things can contribute to their professional formation, the process of which they become professionals. The population was Stanford medical students. Even though my dissertation is with Loma Linda University, the population and my IRB was with Stanford. So we had 12 medical students, and these reflection rounds were at the very beginning of the COVID pandemic. And I used interpretive analytical phenomenological research techniques. IPA examines the contextual features of an experience, not just describing it, but actually in a hermeneutic way, investigating it. The research question that I had was, and this is a phenomenological research question, because if it were any other a method, we might ask different questions of the reflections that medical students or of joys. But what is it like for a medical student to experience joy and challenges during a patient encounter? And I will answer that at the end. Because this is a short talk, I've summarized, this is my study results model that summarizes 7 themes that I found from their reflections of joys, from their reflections and my looking for their joys and challenges. So there were 7 themes and overarching themes. So from at the top, if I take it from the top, everyone had a patient encounter. And from those patient encounters, there was some kind of relational dynamics. All of them, all of their reflections were about relational dynamics. They never talked about process. They never talked about the practice of medicine. They talked about people. And they talked about people, and either I divided those interactions between times when they could connect with people and times when there was dissonance. And I found that when they connected, they always had expressions of joy. And when there was dissonance, there were challenging things that were challenging that they expressed. But a totally unexpected finding, I was not looking for this, but when I went through the transcripts and looked for the nuances of the joys and challenges, I found something totally unexpected. I found that there were times that joys and challenges interconnected in such a way that led the medical student to a discovery, to a new insight, to a new joy. That it was the interconnection of the joys and the challenges that they had that became a gateway to new insight and new joys. So, in the interest of time, I'll just define a gateway experience, which was my unexpected finding. When medical students' expressions of joys and challenges are in a continuum, they often spontaneously lead to discovery. In this study, we identified this as a continuum of interconnected joys and challenges and discovery, and named the finding the gateway experience. The phenomena represented junctions in the participants' stories when they expressed a sequence of joys and challenges, and something brand new emerged. So, next slide, we're going to give you an example of a gateway experience.
Yeah. So this was from one of the, Akiva and I were both co-facilitating on this. And here's an example from one student. We have many here. So the background was the student, had done their reflection. And I said, well, who would like to go, this was in the middle, who'd like to go next? And so she had a patient who was in the outpatient clinic, this student. It was the student's first televisit, so they were working by telephone with the patient. It was the beginning of COVID. It was a mother with 4 children. She was in her 30s, and the chief complaint was abdominal pain. The student's reflection took 2 minutes. So what you see on the slide what you see on the right is the actual language at the transcription of what the student said. And what you see on the left is Akiva's notation of she characterizes the student's expression as a joy or a challenge. So the patient said, we, meaning the patient and the medical, we talked a long time. And let me tell you, I felt no problem taking a really long time. Oh, I usually feel, I'm always like, I'm a medical student and I'm taking too long. No, I took the right amount of time on that call. I was just obviously struck by the fact that it felt a little bit out of nowhere. No one can anticipate that that's going to be on a phone call on your schedule. And when we're so used to just statins and insulin and pressure meds, that was a hard left turn, meaning to hear that significant non-medical concerns. And then the student went on, and really having to come to peace pretty quickly with like this is it. And at some point, like, we can throw all these resources at her, check in on her, but I think ultimately, like, being a human and just being a listening human was the number one therapy delivered that day. And then also, of course, like, it reinforced the tremendous privilege that it is this profession that even as a student, I randomly pick up a phone call of somebody and then I hear this like vulnerability on top of vulnerability shared. So that gives you an example. Akiva, if you would comment on how that's a gateway experience and some of the rhythms that you see between joys and challenges.
So, this student, like 4 other students, this is just a small part of her reflection, but she's quickly saying telling, the joys, the challenge, the joy of being able to take a long time, the conviction that she, as a medical student, I took the right amount of time, the courage she had to do that, but yet also like feeling the vulnerability, like I'm a medical student taking too long. But then she said, no, I took the right amount of time on that call.
Yeah,
So
she was wrestling
she's
back,
going,
wasn't she, Akiva?
exactly.
She
She's
was,
wrestling back and forth with the joy of what happened, to be able to listen to the story of this patient, but at the same time being challenged, like she said, but I also feel like churning and churning. Can you imagine? She's talking about visceral response here,
yeah,
churning inside. But then after she's saying she's churning and churning, she says, but I knew that ultimately being a human and a listening human was the number one therapy delivered that day. And then the joy of reinforcing the privilege of medicine. So, just in this 2 minutes, we see the flow of challenges, we see the flow of joys, but we see her break forth in a gateway experience to a new joy and a new
yeah.
insight.
It's an emergent phenomenon happening in the conversation, in the context of let's call it the container or the clearing of reflection rounds.
So in a phenomenological study, the conclusion, and I'm skipping a part, a lot of the research, a lot of the results, the joys, the challenges, their words. One day I would love to share those with you. But the uh, the findings uh, from a phenomenological study usually come out as a persuasive account of the findings. That is the result of your phenomenological study. And um, go back, go forward. Oh, where's I think there's a slide. Okay. So my research question to recall is, what is it like for medical students to experience joys and challenges during patient encounters? And now this is the phenomenological account of the findings. And I'm going to read this. For medical students, experiencing joys and challenges during patient encounters is like riding a roller coaster. There are the highs, including the excitement of writing for the first time and engaging in conversations with patients and families and hearing their stories. There's the joy of identifying and bonding with their preceptors. And there's the joy of discovering with conviction and delight their own way of practicing medicine. However, there are also the deep lows of helplessness, guilt, numbness, fear, and like the exciting ride of a roller coaster, the urgent desire to get off altogether and to run. I had one student say, I wanted to run out of the room. I felt like I was going to throw up. I wanted to run out of the room. But even more extreme are those jaw-dropping, upside-down, suspended loops and stretches of churning and churning and visceral intestinal upsets. So, can you imagine riding a roller coaster all day long? No, I don't think any of us should. And yet, that's what we're expecting. Think about it. That's what we're expecting. The emotions, the humanness of medical students and all of us doesn't have time to rest. Emotional exhaustion needs periods of rest. This is some of what I'm taking away from my study. Like any physical roller coaster, the human emotions of medical students is intense and in constant motion. They included resonances and dissonances accompanied by bursts of fear, delight, and joy. These, this contributes to emotional distress at times, spiritual distress. And as any roller coaster engineer will tell you, the intense periods of pressure need the release of periods of no pressure at all. And so that's why I am delighted with the 2024 AMA resolution on spirituality. It's a beginning. Well, maybe not a beginning. It's kind of, I know this has been happening for a long time, but the
Yeah,
language,
I'll interject here if I would. You're right. It's not a beginning. It's a
right?
culmination of work that started in the 1990s and over uh, in the 2000s and 15s with all the work of all the pioneers, including you,
Yes,
Dr. Harold.
yes.
You know, I mean, we needed to dig out. This wasn't just like we knew it was right, but you had to demonstrate it in the language of the science and to recognize that medicine is not sometimes an art and sometimes a science, it's both. And this is the interweaving here. And the culmination of that, it took all this time to get into the AMA. So you know when the AMA makes a resolution, it's arrived. Because they always start with no, no, no. And then it's like the reluctant prophet. No, no, no. How can I say no? All right.
So I love the language. It says burnout is a condition characterized by feelings of pervasive energy depletion and exhaustion. Spiritual distress contributes to burnout. And then they say, in the resolution, the practice of, this is the wording, the practice of spirituality may be a protective factor against burnout. With such interventions as reflection rounds, health professionals and students may rekindle their sense of purpose in their chosen vocation. And I love that. I really do, because it's true. We need to be grounded. We need to get off. We need to rest. So they're encouraging self-reflection for the professions and for medical education to begin to make this an integral part of medical training. So we're going to just do a brief theological reflection on the study findings. And I use the gateway experience and Psalm 22, because in Psalm 22, there's a great flow of challenges and sorrows and pain and just agony, really.
And
Uh,
hopes too.
and there is some joy and some hope. But right in the middle of that psalm, there's a sudden prayer that's a gateway. And that gateway moves from the sorrows of, some believe, the cross. It's a gateway to praise and to hope and to joy. So I
And
love that.
reflecting back into the reflection rounds, we see the same dynamic. It's the same dynamic. This is a human dynamic that Akiva's revealing and talking about. It's the dynamic between the students with us are in conversation, back and forth, the joys and challenges, and then we might ask them, so. Um, Tell me, what is it about this that matters to you? Or we get into some language and then suddenly they have an aha, and that becomes they remember, and that becomes like their quote prayer or declaration equivalent. And then there's an emergence into the new insight, the new joy. They move into a new state of being, a new state of formation. Thank you, Akiva. That was your work, and in this is I'm inspired, and I'm so glad that we've partnered on this, and that you found me to join you with this. Truly. Uh, in just a minute, we're going to have some Q&A, but I wanted to just touch on a couple of emerging ideas that have been in the background of our work. And one thing is ringing true. Um, where is the study of being human in medicine? We have all the different ologies. Harold, when we were in medical school, we studied physiology, microbiology, all the different biologies. Then we studied the organologies. We studied cardiology and pulmonology and this and that ology, right? But where is the study of being human? Did you have that class in medical school? No. And they still don't have that class. But it turns out there is such a thing. The study of being and the study of being human is called ontology. It's a long tradition, dates back to the Greeks and with more current philosophers and the ones that I've been immersed with for 3 decades, studying the nature of being human. We can quote, look at Heidegger and a whole bunch of descendants there. So that's what I'm starting to call the missing-ology, ontology. I also want to let me say that and then go on to a couple of things. And so in this view, we look at who are we already when we wake up and we discover, oh, I exist. We exist. I'm a human being. No, we don't even know that. No, we say I exist. We're beings in time. And then we look around, we're in the world. We're biological beings at our core. And then out of that very biology itself, as a consequence of that biology, not separate from, is language. I is language. So we're linguistic beings in coordination with other people over time. We're historical. And it's our nature that we're vulnerable, we're fragile. Well, we know all this, but to be able to put it in this framework allows for deeper appreciation of who we are, and the nature of illness and its impact and who we are as uh, fragile, we're social, we're finite, we're always in mood, inescapable, like a fish in water, and we are care. We not just care, but we are care in the essence of who we are. We are care, and we are concern. Um, this is one of my favorite things. Just a quick moment, and then we'll go into some Q&A. I was at the bedside with the patient one time. I want to talk about, and the patient says to me, "Chaplain, now I know you're a Jewish chaplain, but I don't get how is it that you can be at the bedside and genuinely be with people, whether they're, very religious and prayerful or secular and not, whether they're Jewish or Christian or Muslim or Buddhist. Um, you've, how do you do it?" And then I realized something. I said, it's true. I am Jewish. I am a chaplain, but I'm something else first. I'm something else first. I'm human. And then it popped to mind. I said, that how we have this idea all human beings come out of stem cells. From a single stem cell, all human beings unfold into all the materiality of our body, our bones, our eyes, our kidneys. It's all pluripotential and it's undifferentiated, and then we unfold. And I said, it's also true for our non-material aspects of our being itself, pluripotential and undifferentiated. So I stand in the place of the stem soul, not just the stem cell, it's stem cell and stem soul. And he says, and in the moment he got it, I got it, and it was something that I appreciated. And this happened a long time ago, and I've been talking about it privately with people, but we're now bringing it out into our teaching, and people are finding it, very useful as a way to appreciate the nature of who we are. Stem cells, we're each of us unique, but all of us born of stem cells and stem souls. Now, it's not a new idea, but maybe it's a colloquially, it's a term for now, but it's an idea that we can see going way back in our history. So it's your turn. So let's have a few questions here. What's been stirring or niggling for you that you'd like us to address as we are able?
So one question that was in the chat was that, do we have a manual for reflection rounds yet? And I know that's one of our dreams.
Oh, Marita. Everybody, I want you to meet one of my mentor's longest time friends, the person who in the family medicine got that HHS grant and was with us all the way through to the development of reflection rounds, Marita Grudson. Unmute.
Thank you, Bruce. I just really wanted to comment on how significant your work, both of you, is just for human beings that get sick and have all sorts of tragedies. Um, I have a question, but I first want to acknowledge Dr. Koenig, who has been so wonderful in the field, particularly of gerontology. And he gave my husband and I some warm welcome in his own home. Just a marvelous human being. Um, one of the things that you mentioned, Akiva, or that I saw on the slides, is the issue of time. That all these, the potential risk for burnout, for example, or even suicide, um, the ultimate tragedy. But it seems that part of your research is showing that this roller coaster of emotions, there needs to be some time. And I know that the religious rounds or reflection rounds rather, and the earlier experiences provide a form of time in a very busy context. But I'm hoping that medicine AMA will also provide in the training less time demands on clerks and medical clerks and residents. Um, because it seems that puts people at risk for burnout.
Mhm.
Just, is
Uh,
there any move in that way of AMA? Are they, anyway, you know my question.
Yeah, I think there are lots of other people that can answer that, about the AMA, but absolutely. That's how I would, I mean, absolutely. I hear it from the AMA. I hear it from, uh, the autonomy of physicians being able to decide how much time they need with a patient and to decide it's not a transactional relationship. It's a real relationship and that it takes time. And that is really something I think the AMA is fighting for. But I know Dr. Koenig knows more about that.
yeah, I can
And
jump in with
Bruce.
something too. An important aspect of this, Marita, you and I have talked about it. Medicine is not only about time, it's also about meaning. And having a mindset that allows us to pivot to say, well, what is it about this that prompted you to come in? Now, that didn't take a lot of time, but it shifts the whole conversation into meaning. When we stop, and you and I have talked about this, Marita, and we've put this into the design. We look at little micro moments along the practice of medicine. Like before coming into the room, we don't just rush into the room in our busyness. We stop. It's a little micro moment to prepare my attention and intention. I take a moment as I gel. I use that as an opportunity. I create a ritual out of it. I stop. I breathe. And then my intention. As I enter the room, may I meet you, my patient, in your world as it is for you, and accompany you. That's my central verb. Accompany you from there in a way that allows you to connect with your source of comfort and strength, whatever that means for you. What matters for you is what matters for me. And may I listen for that and respond. And that kind of intention is true whether I'm going as a chaplain or a physician or a respiratory therapist. So I think looking for the design of our practice as well, these elements of mindfulness and intention, uh, is will serve us well as we're moving into a new era. Well, we have a question for everybody. Let me ask, what is, Akiva and I would like to ask everyone, and get ready because we're going to ask you to put it in the chat. So here's our question to you. What is one thing that you're taking away from this conversation today? I know we were talking, but we're all listening and engaged. And as we were speaking, it triggered maybe new questions for you, maybe new ideas, or an affirmation of something about yourself or our profession. What's one thing you're taking away? Please, we invite you, write that down into the chat. Let's see what we discover as a
Wow.
group.
Hmm. Shall I? You, we can read some of them when they start to come in.
Yeah, there we go. Attention and intention. Change does happen. Spirituality is protective for both patients and practitioners.
I
I'm a
love somebody's
volunteer
response
chaplain.
was phenomenology.
Oh, these are rich.
Dr. Koning, can we have a copy of the?
If you will email me, I'm happy to send you a copy of the chat.
Oh, good.
Yeah.
Thank you.
I see earlier in the chat that somebody asked about my prayer. And there's a reference at the bottom of the PDF that we're going to put out. I published it in JAMA as back in 2001 called Toward Meaning. And I go over that actual prayer. In the prayer, I it was an out loud prayer that we had going back and forth. Uh, I joined with her. I held her hand, Mrs. Martinez. Are you a prayerful person? And she said yes. And as we were holding hands, so would you like a prayer? She said yes. And so then I waited for her to begin. Only she was waiting for me to begin. She was twice my age. She was 88. She's from Mexico. I'm from Detroit. She wears a cross. I don't wear a cross, but here we are in the medical, at the bedside, in the context of the medical promise. And so I thought, well, how does a prayer go? Uh, Acknowledge a higher power, ask for something, say thank you, and go home. 4 steps. I could do that. You know, that's how an emergency doctor thinks. and I and I said, Mrs. Martinez, um, let us have that prayer. Oh God, you who are the great healer. And then I paused, thinking, what am I going to say next? And do you know what? She starts to repeat after me. Now, for me, that was stunning, but for somebody who's Catholic, you know, that's like, well, of course, there's this back and forth. And then we went back and forth, and I thought, well, what am I going to say next? Be with us in our time of need is what I said, including mine for deciding how to proceed here. And we went back and forth in this way. Thank you for hearing our prayer. Thank you for hearing our prayer. Um, and then she started to say, Our Father who art in heaven. And I knew that one because I used to work closing shift at the Catholic hospital, and it would be on the loudspeaker. And then she started to say a prayer in Spanish, and it was to Saint Jude, the saint for the hopeless and the destitute, I found out. And it was after that that she then looked up at me and she said, Thank you, doctor. Thank you. And as I said, the color had fully returned. So there was some real physiological change. I'll call it healing when she went from this state of shock and loss of the blood flow to her face now into a visible state of gratitude. So I want to thank everybody again. Akiva and I are available, by email. I see some wonderful friends out here. I see my cousin Lori. Hi, Lori. Nicole is an up and coming leader in spiritual health in this country. She's a chaplain at Stanford Medicine right now. I'm not going to. Peter Yahokovsky is one of the deep thinkers and comes from a tradition of ontological philosophy. We've studied together. I see people from our lifestyle medicine, many, many people here. So that's all I got, Harold. Last word to you. Thanks so much.
Thank you, Bruce and Akiva, for a wonderful, really inspiring presentation, and for, all of the comments that were made here, both in the chat and in questions being asked. And we just hope that you have a great month, and see you next month.
And one more quick shout out to one of the most dear people in my life, also Carol Winograd, who was one of the founders and partner with me when we made that when I made that transition to chaplaincy. We can't do this work alone.
You've got quite a team there, Bruce and Akiva.
Mhm.
God bless you all, and have a great
Thank you.
safe space here.
So do we
Bye.
have our thank you slide, Dr. Koning? We have a special thank you slide for you.
Okay.
All right, let me pull it back up here.
Oh, I'm sorry.
All right, yeah, let's see here. There we go.
Oh, there it is.
Oh my, that's beautiful. I love those trees. That's California.
That's California.
Bye
Thank you
bye,
so
everyone.
much.
Thanks
Bye-bye.
again for everything.